and welcome to the November 2023 episode of Insight here on BCTV. My name is Mark Levengood. I'm the counselor at the Vision Resource Center of Berks County. We always appreciate you giving us a little bit of time each month, and we're excited to have you with us again today. We'd also like to welcome our guest. We have Dr. Dawn Hornberger joining us. Dawn is a doctor of optometry and a low vision specialist, as well as a member of the Vision Resource Center Board of Directors. And our topic for you today is a little bit of a follow-up part two. A couple months ago, we took a look at age-related macular degeneration and geographic atrophy. But today we're going to look at those two conditions, specifically considering how to continue on a functional, practical level after a person has already been diagnosed with them, and how to continue living in spite of those diagnoses. So good morning, Dawn. How are you today?
I'm good. It's good to see you.
Thank you. You as well. Thank you for joining us. And if you could start us out, just a big picture, Dawn, what is age-related macular degeneration?
Age-related macular degeneration is a form of vision loss where the center part of the retina is the lining of the eye. The center part is called the macula. That's the area of the eye that gives us details. It lets us see fine things, things like reading and people's faces and all the things that require detail. That area of the eye breaks down as we get older. There are a few forms of macular degeneration that affect younger people, but for the most part, the most common form is called age-related macular degeneration, and that's what we're going to talk about today.
Okay. And could you differentiate for us between wet versus dry macular degeneration? I think a lot of people have heard of them, heard of these two forms, especially once they start to get into this low vision world, vision impairment world. What's the difference between wet versus dry macular degeneration?
Well, the dry is actually a more gradual, slow atrophy of the retina. Basically, that form is more common, and a lot of times the wet does start out with a little bit of dry. There are basically no major treatments for it at this moment. For the most part, vitamins will be helpful in slowing down the process. And there are some new medications that will work at the end stages called geographic atrophy. But they're very new. The wet form, on the other hand, is a problem that forms because of decreased circulation in the back of the eye. The blood flow is not getting to the eye properly as we get older. You're ending up with not enough nourishment or nutrients getting to that part of the eye to feed it. And also there's not enough of the waste products that are the result of metabolism in our body, taking that away. The blood vessels not only bring good stuff, but they also take away the bad stuff. And neither of those processes are working properly. So when that happens in the back of the eye, many times the body will say, hey, we need better blood supply. And they'll make these new blood vessels, something we call neovascularization. And that process, unfortunately, results in a bunch of blood vessels underneath the retina that are very fragile. And they tend to break and they leak, and fluid and blood leaks into the layers of the retina. And that's what causes the damage from the wet form. For that form, there is actual treatment that is available in the form of a medication or several medications that are called anti-VEGF medications. And basically they're medicines that will inhibit the formation of those blood vessels and allow that fluid and blood to reabsorb into the body. They are unfortunately injections that have to be done on a regular basis. It's not a once and done thing, but there are some treatments for that. So it's usually a more sudden, and in the past, it was a much more severe form of macular degeneration. Of late, I find that many times if it can be caught early, people have actually a better prognosis with the wet than they do with the dry.
Yeah, it is interesting because as you explain wet versus dry, the wet definitely seems more complicated, more involved, more, progressed. And yet it is interesting that that's the one that there's a treatment for.
Yeah, I mean that's been a godsend. I've been in
Sure.
this field long enough to remember the days where there was no good
Mhm.
treatment for that. We could do lasers, and unfortunately, the laser would cause damage to the good retina in the process of cauterizing the blood vessels. So
Mhm.
what you gained by slowing the process down, unfortunately, caused further damage. So
Sure.
these treatments have been really a godsend, and the key is just detecting it early so that those treatments can be put in as early as possible to prevent any long-term damage in the retina.
So, absolutely. Now, is age-related macular degeneration really the leading cause of vision loss in the Western Hemisphere, as I've heard before, and others have too?
I would say that it probably is in more developed nations. Unfortunately, around the world, things
Mhm.
like refractive error, which is just basically needing glasses, and cataracts, which are very treatable in our
Mhm.
world, those are the leading causes of vision loss throughout the world. But in our area, we do seem to see that the macular degeneration is far more common than those problems that are treatable in our society.
I've also heard that pink eye is a huge, one of the biggest leading causes in underdeveloped nations as well. Something that we treat so easily, but it's so contagious. And you know,
Yeah. Yeah,
now what?
we are very blessed.
Why do you think age-related macular degeneration is so prevalent here in the Western Hemisphere and in other developed nations?
Well, there are a number of risk factors for macular degeneration.
Mhm.
One is age. Being greater than age 50 is normally what's considered the cutoff.
Mhm.
Not that it can't happen lower than that, but for the most
Right.
part, this form of macular degeneration usually starts over age 50. And
Mhm.
so I guess in developing nations, people don't live that long. So we're blessed in that we live longer, but the longer
Right.
you live, the more likely you'll have this.
Right.
Smoking is also a big factor, probably the
Okay.
most controllable factor in macular degeneration is smoking. And
Mhm.
a diet high in fat and sugar, things that are bad dietary things can be certainly a contributing factor, which I guess our diet is sort of like that. And things like high blood pressure and diabetes, which are more common in our society.
Mhm.
Many times UV light exposure can be also a significant risk factor, although in certain nations that probably would be, not necessarily a higher risk factor for those of us who live
Mhm.
in the Western Hemisphere. But
Sure.
certainly a lot of the controllable things are the diet and the smoking, and those are things that we all could do better with, I'm sure.
Yes, absolutely. Now, Dawn, you mentioned geographic atrophy briefly earlier. Could you explain for us what is it? We've heard a lot about it recently in television, radio commercials, but what is it?
Geographic atrophy just is a term that refers to the end stage of macular degeneration. So
Hmm.
it can be from the wet or the dry, and basically it's just a giant scar. Basically the back part of the eye is no longer functional. The retina has
Hmm.
basically completely destroyed itself, and
Hmm.
now you have a very large scar. Now, in the earlier stages, you might have still areas of retina that are still functioning surrounding the areas that are atrophied. But in the very end stage of macular degeneration, that large sort of geographic atrophy scar can be one very large scar that causes a blind spot in this
Hmm.
entire central part of the vision.
Okay. And you said it geographic atrophy uh, impacts both dry and wet.
Yeah, so it's basically the end stage of
Okay.
both of those processes.
Okay. And can you also briefly mention juvenile macular degeneration earlier, such as like Stargardt's disease? Can that also, excuse me, can that also lead to geographic atrophy?
It can look very similar. It's a totally different functional process, though.
Hmm.
Basically, macular degeneration that's age-related is related to buildup of waste products in underneath the retina, something we call drusen, and poor circulation in the area. Whereas Stargardt's is a very genetically driven disease, and the
Hmm.
process itself is different. However, the end result and what it looks like in the eye looks very similar, and so you could call it geographic atrophy in that as well, but I don't know that the same treatment protocols would work in that
Hmm.
disease process because it's a different reason why people are losing vision from it.
Sure. And that makes sense. Yeah. And kind of the same end result, but a different way to get there. So maybe a different
Yeah.
treatment altogether. Yeah. So, Dawn, could you explain for us, what does low vision care look like, both from your perspective as the professional doctor, as well as from the patient's perspective?
Well, basically a low vision evaluation would involve looking at various optical and non-optical devices that may allow someone to function better. So basically, when I'm seeing somebody for a low vision evaluation, they've already been evaluated by a medical provider, either an optometrist or an ophthalmologist that has determined that there isn't anything that can be done to fix the problem that they have. So I'm getting them basically, okay, what do we do now functionally to help somebody be able to do their day-to-day skills and their life better? So basically, we're looking at, initially, we do a very thorough history on, and it's very task-centered history, basically on what are your desires, what are the things you're struggling with, what specific tasks are giving you difficulty, because the type of device or tool or method that's effective in one task is not necessarily what's going to work for something else. So the idea of we're going to put on one pair of glasses and everything's going to be perfect again is not at all what we end up doing. You might have multiple pairs of glasses for different tasks. So we're doing a refraction, not just a normal refraction, which sometimes people are like, well, I just had my eyes refracted. Why do I need to have this again? Well, we're not only looking at what's your best distance correction, but we're looking at, okay, if you're trying to work with a computer, can we find something that's going to work at that distance that's helpful? Are we looking for a much stronger reading pair of glasses than what would normally be prescribed? And then we're also working with magnifiers and telescopes and electronic magnification and things called CCTVs, which are closed circuit TVs, which are, again, an electronic means of magnification. And then also what I do in a low vision evaluation is I would be looking at non-optical tools. So there may be other devices or other recommendations that I can make that would allow someone to function better. And then I connect them with other resources in the community, places like the Vision Resource Center, where they can receive other services that I don't provide, that maybe are not necessarily optical in nature. We might refer them to an agency called Blindness and Visual Services or other similar agencies where they might be able to achieve funding assistance, or someone who would help them with their mobility, someone who would maybe connect them with transportation resources, or other things to help them to be able to function in their home. It may be that marking the dials on their stove in a certain way will allow them to function better. So not everything is an optical answer. And so I try to be very thorough with making sure that they're connected in with, if they need counseling services or whatever it might be, that they're also being connected into those other resources that are not necessarily the things I'm going to help them with.
Right. So you can function as like a conduit and a connecting point to launch them in the right direction.
Yes.
Okay. So also, Dawn, what happens on a practical functional level to a person's field of vision after they've been diagnosed with macular degeneration, geographic atrophy? Like, practically, functionally speaking, what's going on? What can they see? What can't they see?
In many cases, people have family members who think that they're faking it because they have perfectly normal peripheral vision. The problem is peripheral vision is designed to be able to see objects, to let you know something's there so you don't crash into it, but it isn't designed for detail. So knowing who that person is that you might be crashing into is not necessarily something you're going to be able to see. You might not be able to see to read or to write or to drive a car or watch TV or things like that. Those may be difficult. See the dials on your appliances, things like that. But you could see to walk around. You're not probably going to be bumping into things. You're probably going to be able to navigate through your home pretty well. You might find that you have a little trouble seeing depth perception or drop-offs like curbs and things like that, or color may not be what it used to be. Contrast may not be what it used to be. But for the most part, part, what you're losing is your central vision. So some people will describe that as a feeling of just distortion in the central vision. Some people will experience it as a missing thing, that there's parts that are missing, like they might look at your face and there's pieces of your face that aren't there. It's sort of like looking at a jigsaw puzzle that's missing pieces. Some people will describe it as a black spot in their vision. And the geographic atrophy can, and I've had people describe it in both ways, that they have a large area that's missing, or that they have a large area where there's like a black blob that gets in the way. And sometimes it's just a distortion. Sometimes there's pieces of the retina that are still good surrounding an area that's bad. And that person sometimes functions much worse than somebody who has a large area that's missing, because they might have a tiny little island of good vision that they're trying to use, but it's not big enough to fit things in. So that can be a problem. So everybody has a little bit different experience. And I will be very honest, in working with people who are visually impaired, and the majority of the people I work with have macular degeneration. The person who can't see the giant E on the chart is many times the person I can provide better assistance to than the person who has good enough vision to drive a car.
That's interesting.
So acuity, what we read on an eye chart, is really very irrelevant to how well someone functions. They might have a little tiny island of acuity that if they see one letter at a time, they do really well. But putting those letters together to make a word out of it may be very difficult because they're not seeing the whole word at one time. So functioning, people often say, well, what's my level of vision? Well, you know what? We record that, but it's a whole lot more than that that's going on. It's how is this blind spot interfering? How much are you able to work around that? Do you have cognitive issues that are affecting your ability to do that? Do you have other comorbidities, other problems that are happening in your life, whether it be hearing or hands that don't work as well as they used to, or things like that? So, each person is very, very different.
Sure. And I know earlier you mentioned a number of different assistive technologies and low vision devices that can help people with AMD and geographic atrophy compensate for their vision loss. So kind of collecting it all together, how is it that people can use those devices despite macular degeneration, geographic atrophy, and still do basic daily activities of life like reading and writing, personal grooming and hygiene, cooking, etc.? Like how does this work?
A lot of the tools that we have are based on magnification. So as long as we can make things big enough, if the blind spot is small enough, it doesn't interfere as much. So if you think about, if you have a blind spot the size of a pin of a head, or the head of a pin, and you have an object as big as a chair, well, so what? You're missing that tiny little spot. Who cares? You still know it's a chair.
Sure.
But if you have a letter that's the size of the head of the pin, now you're not going to see that letter. So the bigger you make something, usually the less the blind spot interferes. So many times the devices are geared toward magnifying. And depending on what the task is, you may want more or less magnification to do that task. So that's where these different tools, a lot of them rely on magnification. Sometimes we're doing things with a different sense. We're teaching somebody to not use their vision. An example I like to give is, I don't know the last time I looked for the light switch when I walked into a room. You know where a light switch is going to be, and you reach around and you turn it on before you even go in the room.
Sure.
Most people, that's what we would do, even if we have good vision. So there are lots of things that can be taught, as you well know, to be done in a different way. Whether you're using your hearing, you're using your touch, you're using other senses to be able to do those tasks. Certainly that's part of it as well. But the part that I'm most familiar with working with in a low vision evaluation, or as an eye doctor, I tend to work with the magnification tools. And we've got anything from glasses to hand magnifiers to electronic magnification to voice technology that we connect people to ways to enlarge things on your computer or on your cell phone. Or there's even devices that look like those virtual reality type helmets that people wear, and basically it's a giant device that you wear like a visor on
Right.
across your eyes. In fact, one of them is called the Geordie, after the Geordie in Star Trek, who had his special little visor glasses that he wore. So there are different devices like that we can use as well. But each one is tailored to what are the needs of the patient, and what are their other issues. Are they, a 90-year-old who can barely use their hands because they have such severe arthritis? Well, then maybe a handheld magnifier is not going to be the best thing, or a certain type of magnifier might work better. So, everything is kind of geared toward the individual.
Certainly, yeah. Now, earlier you mentioned about people with macular degeneration sometimes still drive, which I got to be honest, blows my mind. But how often do people, or how quickly after a person is diagnosed with macular degeneration or geographic atrophy, how quickly is it that they ultimately have to relinquish their ability to drive and give up their driver's license? And, have you ever had to deliver this news to someone? And if so, what's that like?
Basically, that the answer to the first part of the question is it is very variable. I mean, you can have people who have macular degeneration for 20, 25 years, and they still maintain vision in one eye that allows them to continue driving. They may also have, just decent acuity. And the law requires that you have a certain level of visual acuity, and it also requires you to have a certain amount of peripheral visual field. So I'm personally more worried about the person who has no side vision driving a car, because they don't even know what they're not seeing, versus the person who has central vision loss, that mainly it affects the clarity of their vision, not so much that they're having a big enough blind spot that it would interfere with them seeing an object. But it's really variable. I mean, there are some people who can maintain vision into late age and still be okay to drive. And then there are people who lose the vision very suddenly, especially those with wet. It may happen very suddenly, and then they may have to be told not to drive. But it's mostly it's a slow process. And yes, I have unfortunately had to be the one to tell people not to drive many times. And unfortunately, Pennsylvania, or fortunately, maybe, I don't know whether this is a good or bad thing. I think it's a bad thing. Pennsylvania law states that any doctor or person who has any authority who realizes that someone does not meet the criteria for driving in the state is required to report that. But you can get a driver's license in Pennsylvania at the age of 16, go blind at 17, and drive for the rest of your life, even though you're blind.
Wow.
Because nobody ever asks you to retest.
Right.
Unless you randomly get a paper from the state. So that is a problem, because then the doctors become the bad guy.
Right.
And so I've had people get very angry at me and storm out of my office because I told them they can't legally drive. And it's our legal obligation. And to be very honest, it's like if somebody continues to drive after we've told them not to and we've reported that, we could actually be fined or lose our license or more, or sued if they get in an accident, if we haven't done that. And the state puts it on the doctors to do that. So it's bad in that, people are then afraid to come to an eye doctor for fear that they may lose their license. But the reality is I've also been the one who has been there when I've told somebody they legally can't drive anymore, and they've gotten angry and stormed out of the office, and then come back a couple of years later. And in this one particular case, their wife was no longer with them because the woman died in the car accident that the man caused. So it gives me chills even today to think about that conversation, because it's not just about you. It's about all the other people that are out on the road. And if you're not being responsible with the way you're driving, you're not only endangering yourself, but you're endangering everybody else who's out there, or the little kid, or, whoever, it doesn't even have to be somebody else in a vehicle. It could be somebody who's walking on a sidewalk or crossing the street. So, it is an important thing. And it's very heart-wrenching, and it's many times the worst part of a low vision evaluation if I have to be the one who brings that news to someone.
Right.
Many times they've been told it before
Right.
they're reaching me, but it often is not a good part.
Yeah, and I can tell you too, as the counselor at VRC, a lot of people who do ultimately face that need to give up their license and stop driving, there is a real feeling like they've lost independence, where they've gone from total independence to total dependence, at least in terms of transportation. And that's one of the biggest struggles I hear that I hear at Vision Resource Center as the counselor. A lot of people struggle with that.
Yes.
So now, Dawn, what is the most common struggle or complaint that you have heard through your years from people with macular degeneration and geographic atrophy, where they're hoping that you can help them to correct it or resolve it, or at least help them to accommodate it so that they can keep going?
I would say the most common thing is reading, followed shortly beyond that with driving. That they would hope that I'm going to help them with driving, being able to see a computer or television, seeing their phone, mobility or daily living skills like cooking and that kind of thing. But probably reading and transportation are the two main things.
Mm-hmm. Yeah. Okay. So, considering the wide-reaching impact of macular degeneration and geographic atrophy on not only vision but just life in general, are there any means of prevention or being proactive against developing these conditions?
As we talked about earlier, the number one thing is either don't ever smoke or quit smoking, if that's possible. And there are some assistive ways that your doctor can work with you to do that. Smoking is number one in the risk factors for just about every major health problem that we have. But certainly for macular degeneration, it's the top. Also eating well, making sure that you're eating nourishing vegetables and fruits, and certainly the colorful stuff is what's good for us.
Right.
There are vitamins. In fact, there's something called, people have probably heard of the Arids 2 version of a vitamin. The brand name would be Preservision, but there are a couple of others that have the similar formula. And what that means is the AREDS stands for Age-Related Eye Disease Study number 2. Is the formula that they did an extensive research study and found that this was most helpful in slowing down the progression of macular degeneration once it hit a certain level. So that lutein is a major thing. Lutein and zeaxanthin are two bioavailable pigments that are something that helps to protect the retina, sort of like I would sort of liken it to sunscreen to protect the macular area. So I do feel that, that's very helpful for people to use. UV sunglasses, something that has good quality UV protection on sunglasses, making sure you're treating things like diabetes and high blood pressure and other circulation issues so that you are getting the best possible circulation to that area. And certainly regular eye exams to detect things at an early stage where they are more treatable. If you do develop the wet, that we can get those injections in as quickly as possible to help you preserve as much retina as possible. And as these new treatments become available, that you're in the connection to someone who knows about them, that, many times I'll have patients say, well, the doctor said they couldn't do anything for me, so why should I ever come to you? Or why should I ever keep coming to an eye doctor? And the reality is that just because you have macular degeneration doesn't mean that you can't also develop cataracts or glaucoma, or that the lenses from the cataract surgery can't get cloudy, or that you have a corneal problem, or other things that impact your eyes. So, we certainly are checking on that, but also it puts you into somebody who can maybe connect you to these new treatments when they become available.
So, Dawn, as we begin to close, if any of our viewers today are struggling with macular degeneration and or geographic atrophy, and they're interested in possibly working with you to hopefully develop a better quality of life using some of those assistive technologies and low vision devices that we discussed earlier to do their activities of daily living, what should they do to go about getting an appointment with you?
Well, I actually have two offices of my own. It's
Mhm.
called Burke's Family Eye Care. I have an office in Warnersville, and I also have an office in Birdsboro.
Mhm.
And the phone numbers there would be 610-678-7202 and 610-582-6000. I also am the low vision consultant with Eye Consultants of Pennsylvania at Granite Point in Wyomissing, and their
Mhm.
phone number is 610-378-1344. I am
Mhm.
there on a limited basis, but I am there as well. So, I have three different places that people can reach me in Berks County.
Okay.
If funding assistance is needed, they can contact Blindness and Visual Services prior to seeing me, and they will
Mhm.
authorize the low vision evaluation if it's deemed necessary.
Mhm.
And their phone number would be 570-826-2361. If you live in Berks County, that would be in Wilkes-Barre, but you don't have to go there. Just call the phone number and they can assist you. And certainly the
Absolutely.
Vision Resource Center is a wonderful resource of letting people know where to go and how to get help within our
Mhm.
community.
Absolutely. All right, Dawn. Well, thank you so much for joining us today and giving us some of your professional perspectives regarding, what to do for macular degeneration and geographic atrophy. Hopefully, giving people encouragement and confidence and hope that life doesn't have to stop. You just have to figure out how to compensate for it, adapt for it, and keep going. And hopefully, they now have a better appreciation of how to do that.
Thanks, Mark.
Yep, thank you. And to our viewers, again, hopefully you did enjoy the program. And again, if you or if any of your friends or loved ones have macular degeneration and geographic atrophy, don't give up. You can keep going. Dawn just gave all the number of different ways that you can learn more about what that looks like and how to adapt and how to keep going with life just in a different way.